So my name's Gabriel Leger. I'm one of the neurologists here. I'm actually a behavioral neurologist, and my interests are in young onset dementias. So those are dementias, in particular Alzheimer's disease and frontotemporal dementia are the two dementias that I see most often. And frontotemporal dementia is interesting in part because it can frequently present with word finding difficulties.
No.
You can't hear me at all?
No.
Oh, it's not for, so I should just speak more loudly? Okay. So I'm interested in aphasia, which is difficulty expressing yourself, difficulty using words to express ideas. And it's, what I'm finding is that it's something that's very common. So a lot of people complain of having difficulties coming up with words or expressing themselves. It's something that we see frequently in clinic, and it's actually something that we see frequently just talking to people at parties and at get-togethers. So I thought I'd clarify or spend some time talking about what it is that we're experiencing when we're having trouble coming up with our words, having trouble expressing ourselves. And I thought I would do that in a kind of a mechanistic way. We're going to look at how it is that the brain comes up with what to say and how to say it. It's a little bit, it will be at times a little bit technical. We'll be showing pictures of brains and parts of brains and labels that we give to different parts of the brain that are involved in language. I appreciate that might not be sort of generally what we do here, but I would really encourage you to interrupt and to allow me to explore these brain regions with you so that we can try to make sense of how it is that we speak to each other. So trouble finding words is actually a very common complaint, something we hear frequently, as I mentioned, but it doesn't mean the same thing for everybody. So when somebody says, well, I'm having trouble coming up with words, the next question should be, well, what do you mean? What does that mean, having trouble coming up with words? So here are some examples. I'm having trouble finding my words. I'm having trouble remembering names of people or names of places or sometimes names of objects. I'm having trouble getting the words out. I know what I want to say, but the words are just they're not coming out of my mouth for some reason. Or I'm using the wrong words. I think I know what I want to say, but the words that are coming out are not the words that I intend. And sometimes the person that says that, the word that's coming out is the wrong word, isn't the person that's speaking, but the person that's listening, that realizes the word that's coming out is the wrong word. Sometimes we hear complaints about words being jumbled, or the words are mixed up, or the words don't sound like normal words. Sometimes people complain, they say, I just don't have the same vocabulary that I used to do. I used to be able to pull out very fancy words or big words, and now I just can't do that anymore. Sometimes the sounds that are coming out of our mouth, as I said earlier, the words sound funny. Well, sometimes the sounds aren't even words. They're unusual utterances that don't really qualify as words. Sometimes we realize that people are doing grammatical mistakes. So they're saying something, and if we look at what they've said, it's grammatically not structured properly, and so we appreciate, well, maybe the idea isn't being communicated properly. Maybe there's a problem with what they're saying and what they're thinking not quite being the same, not quite being fully matched. And then there's things that are very common in day-to-day, things like stuttering, the quality. Now I'm trying to shout and speak more clearly because I'm speaking loudly, and hopefully you'll appreciate that my voice quality is better than it was 5 minutes ago. Sometimes people don't have anything to say, which is also striking at times. We have caregivers who bring their loved one in and they say, he doesn't talk, he doesn't say anything. Does that mean that they have an aphasia? Sometimes. So what will we talk about? Well, as I mentioned, we're going to talk about how speech is produced. What does it mean to produce speech, and how does it happen in the brain? We'll not talk about stroke, which is the most frequent cause of loss of speech. The most frequent cause of aphasia is stroke, but I won't be specifically talking about that. Instead, I'll be talking about speech and loss of speech in the context of the disorders that we treat here, the neurodegenerative disorders. And those are typically Alzheimer's disease, frontotemporal dementia, and 2 disorders that fall under the rubric primary progressive aphasia, so progressive speech difficulties, which are sort of within the same realm as the frontotemporal dementias. So what is speech? What is speech?
It's talking friendly.
Yeah, talking freely. Like what you just did is speech. I asked you a question and you responded. That's speech. It was spontaneous. It was volitional. You decided that you were going to answer my question. You could have chosen not to. Thank you. It's a conscious mental effort to say something. You have to assemble complex linguistic objects, words that mean things, and connection words that put the words together to allow you to utter something that actually flows and makes sense. And it has to express a meaningful idea. Otherwise, it's not really speech. It's not helpful. It's not what speech was meant for. What it is not are things that are spoken without a formulation in your brain. So if I ask you to recite the days of the week, start with Sunday.
Sunday, Monday, Tuesday, Wednesday, Thursday, Friday, the weekend, Saturday.
Saturday, right. So that's an automatic response. You don't really have to think. Maybe you had to think about it a little bit. But you didn't have to think too much about what do I want to tell him. You say, well, I start with Sunday, and I say the one. So it's automatic. It's an automatic response, which doesn't really change. I could have asked you start with Saturday, and then you would have said Saturday. It would still been exactly the same response, although in a different order. But the words that come out are the same, and they don't matter what you're thinking. It's not a thoughtful, meaningful effort that you have to do to get those words out. It's automated, effortless, and it's ready-made. And sometimes we have expressions like, ah, damn it, or oh, I don't know, people that always say the same thing, these little sort of trademark utterances that people like to say more frequently. So that's not what we mean by speech. So sometimes people can come up with very complex utterances that they do all the time, and we think, well, sometimes they speak really well. Well, not if it was one of these automatic kind of responses. Typically, automatic responses like that are very highly learned. So here's some examples of what we mean by propositional speech. She's exquisite and heartbreaking. So clearly the person saying that has been thinking about something and is responding to a feeling, as opposed to Monday, Tuesday, Wednesday, or 1, 2, 3, or damn, or oh my God. These are not things that constitute what I mean by speech today. So how do we evaluate language in general? Well, typically, the first thing we do is we simply listen. We listen. Sometimes people don't have much to say, so we need to bring them to say something. So we'll give them something to look at or something to respond to, or ask them a question like, what did you have for dinner last night?
Oh, I have to think.
You do have to think, don't you?
I had a breakfast for dinner.
Breakfast for dinner.
And potatoes and toast.
Oh, was it nice? Was it tasty?
It was light and tasty.
Okay. So we just had a conversation because you have something to talk about. Your dinner, your breakfast dinner yesterday. So if the person doesn't spontaneously start talking about something, then we offer a cue, a visual stimulus of some sort, or we might ask them to tell us about their day yesterday or what they had for dinner. And hopefully that will get somewhere. But what you just did when I asked you, what did you have for dinner, that's complicated. That's really complicated. If you think about it for a second, what is it that just happened when I did that? Well, you had to convey a thought or a message in verbal form. So that starts with, well, dinner. You know, what's dinner? What was it? You have to put yourself back in context to last night. You were sitting with maybe your husband, and did you make the meal? You cooked it yourself?
We went out.
Oh, you went out. Okay. So was the service friendly?
Yes, it was.
It was.
Very nice.
So it was overall a pleasant experience. You have very positive thoughts about it. Yeah. So in fact, you did smile when you said it, and we could tell that it was a positive experience. You weren't angry, or you weren't disappointed about having to tell me about something that you didn't enjoy.
Correct.
Yeah. And that was captured as well in what you told me, in the way you said it. But anyway, we have to engage in the conversation. We have to understand what was being asked of us, and choose what it is that we want to say. So you decided to talk about your breakfast rather than your dinner. So you changed the topic a little bit for me. We have to select the words that we're going to use to express what it is that happened or that we want to talk about. And then we have to put those words in a certain structure. We have to put them in an order that makes sense to all of us. It's called English. And it follows grammatical rules. And then finally, after we've all done all that in our head, we need to say it. It needs to come out. It needs to come out as a series of utterances that are going to be formed by the vocal cords and by the tongue and by the lips and by the teeth. And that, too, is a fairly complex process that you didn't think about when you just told me what you had for breakfast last night. Yeah. So this is sort of the plan, and we're going to follow this structure through the rest of the lecture. We're going to talk about planning your verbal message, about elaborating your message with words, about structuring your message, your words, structuring your message with grammar, and then finally delivering the message with the motor systems. But before I do that, I'd like to talk a little bit about memory. And we've already talked a little bit about memory, because when I asked you what you had for dinner last night, you had to start using your memory, and you had to start thinking about what it is that you were going to say. So let's say a few comments about memory. The first is that there are many types of memory. And I think we all inherently understand that there's short-term memory and long-term memory. Typically, short-term memory is when you have to remember a telephone number between the time when somebody told you over the telephone and the time you got to the pad to write it down. That's short-term memory. It's very short-term. And we also call that working memory, because you have to keep it active in your mind in order to write it down. If you trip and fall, the number's gone. You're not going to remember it. Long-term memory is different. Once you've committed something to long-term memory, it's there, even though you trip and fall. You'll be able to remember it later. Long-term memory can be divided into two types: explicit memory, memory that you're conscious of, and implicit memory or unconscious memory. I'm just going to quickly refer to implicit memory in that it's what we sometimes think of as procedural memory, like driving a bike or writing or doing simple types of drawings or writings, or buttoning up a shirt. These are things that are learned, motor skills that are learned, so you know them, they're part of your memory, but you're not usually aware that you're using your memory to do those things. Explicit memory or conscious memory can be divided up into two different forms. The first is episodic memory. So we've already cashed in on your episodic memory. We said, so what is it that I did? And you went back in time and you imagined yourself sitting at the restaurant with your husband, and you imagined the nice waiter or waitress? Waitress. I imagine your husband enjoyed the situation more than you did.
Yes, I think probably so. That's where the tip comes in.
Is that right? So this is what we call autobiographical memory. So you go back in time, you remember the events as they took place, and you put all that together. And why is that important for speech? Well, that's what you're going to talk about, isn't it? I've asked you to tell me about it, so you're not going to be able to tell me if you don't have any memories of what you ate last night. You're going to go, but you didn't do that. So that's episodic memory. Semantic memory, so that's episodic memory. And I'll just point out what you had to do to come up with that episodic memory. You had to use a large number of systems in your brain. The most important of that system is the hippocampal formation, which is this area here, the hippocampus. We call that the memory center in general. It's the part that's affected first in Alzheimer's disease. And it's the part that prevents us from going back in time and remembering what we did yesterday or the day before. But there are lots of other systems here that are involved, including the part of the inside of the frontal lobes, called the prefrontal cortex, which kind of motivates us to remember things. It puts things in perspective. It makes us choose to talk about a particular thing. That's what drives our desires and our actions. And then the rest of the systems there sort of connects it all together and allows memories to be formed, and also memories to be recalled later. Now, the other kind of memory that's episodic or explicit is semantic memory. That's a little bit more interesting, a little bit more it's not as conscious as we might think. It's not as conscious as episodic memory. Semantic memory is general knowledge of things. So the first thing I'll do is I'll just show you what supports this episodic memory. Semantic memory. Semantic memory is supported by a system that surrounds the hippocampus here, the inferior temporal lobes. That's where the semantic memory generally depends more on that part of the brain. So just a few more, just a little bit more to clarify what the difference between episodic memory and semantic memory. We've already been through this. What is episodic memory? Well, there are these. If you ask yourself these questions, you'll be probing your episodic memory. Where did you have dinner last night? Who was there? Did you enjoy your food? Did you enjoy the company? That's episodic memory, long-term memory that's associated with, that's autobiographical, and that is generally consistent with a collection of past experiences that occurred at a particular time and date. And as I mentioned, that's generally the deficit that first appears in Alzheimer's disease. I'll be talking about semantic memory a little bit more in detail later. So when you want to plan your message, what you want to do is to probe your episodic memory and decide what you want to talk about. And as I mentioned, if you don't have a whole lot there, if you don't have a whole lot to talk about, you may not have anything to say. And you might be people around you, if you don't answer their questions, or if you don't have any data to answer questions, people might think that you have an aphasia. Again, I'm showing you the structures, again, simply because the next slide I'm going to show you will be some MRIs and some actual brains of patients with Alzheimer's disease. But remember, this is the area that's affected first and most in Alzheimer's disease. And as you can see from this picture here, a patient with Alzheimer's disease, the hippocampi, the memory centers, just to put things in perspective again, we're seeing the brain from the middle outward. So we're seeing the temporal lobes. This area here, we're seeing the temporal lobes from the middle. And on this picture, we're seeing, at the bottom, we're seeing the temporal lobes as they're cut this way. And as what you can appreciate is that the temporal lobes, particularly the memory centers, are atrophied, they're gone. And that's what we see in Alzheimer's disease. I mentioned that this area here, what we call the prefrontal cortex, on this picture it's called the mesial frontal cortex, the part that's inside in the middle, is responsible for motivating, for choosing what we're going to be talking about, for what we want to do. And in frontotemporal dementia, that's one of the areas that's most affected early as well. So people with frontotemporal dementia might not have a whole lot to say. They might not be very interested in talking. And so that first part of especially spontaneously, if they're not involved in their past actions, or they're not interested by their past actions, they won't want to talk about it. They don't have anything to say. And as you can see from this picture, that part of the brain is generally significantly affected in early frontotemporal dementia. So here's a question. What's a giraffe? I'm looking at you. Yep. Am I talking to you? Yeah. 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 Yeah, that's exactly right. So when I said, what's a giraffe, all of you thought, well, you've probably imagined a picture of a giraffe in your mind. That's generally what happens when I ask the question, what's a giraffe? You'll think, oh, it's a tall animal with a very long neck. You might have thought about a bunch of other things, like, oh, I might have seen it in, they might be present in Africa somewhere. They might run away from lions or tigers, probably lions. They're herbivores. You might have thought all of these things. And you might, so this is semantic memory. This is knowledge that you have about giraffes. This is stuff that you know about giraffes. You might even have attached that semantic memory to an episodic memory about when you went to Africa and you saw a giraffe. And so you remembered experience, or at the zoo, yeah, or at the zoo. So here's some information about a giraffe. They have a long neck, they live in Africa, they're herbivores, they have brown spots on a yellow background. And how many of you knew that giraffes hang out in towers? That's what a group of giraffe is called, a tower. I didn't know that. That's my semantic knowledge of giraffes increased by 25% when I did this. So that's what happens. I say, well, what's a giraffe? And then, bam, all of this stuff comes into your mind. And that's important. That's important information because it allows you to put the concept of the giraffe in perspective. And you can get to the word giraffe, which is also part of the semantics of giraffe, is the word giraffe. It allows you to access that information if you need it to talk about it. So that's what semantic knowledge is. It's a portion of long-term memory that draws from ideas and concepts, but not generally from personal experience. So it includes common knowledge about the names of colors, of animals, sounds of the letters, and facts about the objects. So when we elaborate a message with words, that's where we're getting the words from. We're getting them from our semantic stores. So if you have trouble picking your words from your semantic store, from your vocabulary, if you have a limited vocabulary, then you're going to have trouble putting a sentence together to talk about a giraffe. And you might be looking for words. So instead of saying, well, giraffes hang out in towers, you might say something like, well, giraffes hang out in big groups, which is different and not as quite as precise as to say in towers. So there are a couple of reasons why you might not be able to access the semantic fund of knowledge. One is that the semantic fund of knowledge is damaged, and the other is that the connections to it are damaged. So just, I guess I put these together last night, and I really wanted to push forward the brain and the parts of the brain that were affected. So just so you remember, the part of the brain where the semantic information is stored and manipulated is here in the inferior temporal lobe, generally on the left side of the brain. So what happens if you lose these connections, or if the vocabulary shrinks? Well, your language will change, because in order to say things, you're going to have to replace the words or use other words to express the idea. So typically what happens is the language becomes more circumlocucious. People will experience circumlocution, which is the use of imprecise expressions or the use of more words to say a single thing than you might have needed to say if you knew exactly what word to use. So if you don't know the word Africa, you might have had to say, well, giraffes live in this place. It's the big continent that's just underneath Asia and, you know, the place where giraffes live. So that's circumlocution. You might have said something like, oh, it's the place where the desert is. So you know a little bit more about Africa, but not enough to know that it's Africa. So that's circumlocution. Sometimes you might come up with the wrong words. So coming up with the wrong words when you're looking for, say the word tower of giraffes. Now, I didn't know that giraffes hung out in towers, but I might have said giraffes hang out in herds, which wouldn't have been wrong. I think all of you would have understood what I meant by that, but I'm wrong. They don't hang out in herds, they hang out in towers. So although this mistake is not a really big one, you can imagine there are circumstances where it would be more obvious. So people might use words that are close but not quite right, so dog instead of cat. And sometimes the words become less precise. So cat is just as precise as dog, it's just the wrong word. Just like herd is just as precise as tower, it's the wrong word. But to say animal instead of dog is different. It's not as precise because a dog is an animal, but not all animals are dogs. So it's a supraordinate word that describes the concept of dog, but not as precisely as dog would. So that's all part of the semantics. I wanted to show a few videos. So this is a gentleman who actually has a disorder called semantic dementia. His semantic stores, this place where all of this information is stored, is breaking down. And he has a lot of trouble saying things. He has to spend a lot of time using many words, often very vague words like, you know, I can't do that. And he's using his hands and he's pointing at things throughout. So I just asked him the simple question, what's wrong? Why am I seeing you? You know, what's the principal problem? How to say? To see a thing like that. I can't say what it's called. Okay, that's
alors, ce qui vous dérange le plus, si je comprends bien, donc, vous avez la difficulté à nommer les objets qui sont devant vous. Okay.
So I said it in words. You have trouble naming things.
Non, je suis comme ça. Je veux dire, je sais que ici, je ne suis pas capable de vous donner quelque chose.
Ouais.
Ben, il me reste à moi. Je vais m'arranger avec eux.
D'accord.
So I don't know how many of you speak French, but the linguistics were wrong. He was very vague. I asked him to tell me, I specifically said, so you have trouble finding words, naming things, and he went off on how he was close to his family. So I don't think he understands very well either. I don't think he has a full grasp of what I'm asking him to do. Now, he has trouble with, and I'll show you another small movie. He's gonna see an accordion, and he's gonna tell us how to use it. He's not gonna be able to name it, though. And then he's going to see another object, and I'll let you decide what's going on.
Ça, c'est quoi? Ok, c'est beau. Ça, c'est quoi?
Ça aussi,
Ah ouais?
So he has no idea what an asparagus is. He doesn't know. He doesn't understand the concept of an asparagus. So if I had said, what color is that thing, he might have said silver, because he thinks it's a flute. Or clarinet. A flute is played this way. But in French, a flute is it's played this way.
But when I first saw it, I thought, I was looking at the bottom only, and I thought of flute.
You thought too? Yeah.
And then I got up to the top.
Well, that's interesting too. I don't think there's anything wrong with what you did. But you're right, it does look like something you would blow in. And he was primed because the picture before that was an instrument, so he was in that part of the brain or that part of his semantic knowledge base that codes for musical instruments. So it probably wasn't fair on my part to do that to him. You could wonder, does he perceive the object properly? Does he actually see the object? Does he see that it's a straight line with these little outcroppings, these little things on the side? He doesn't know that it's green because it's not colored. So is he perceiving the object properly? And that's something that comes up when you ask people to name things. Right? Is it because they don't have the knowledge, the information of where the words are? Is that lost? Or is it that they just didn't make the connection between the visual part of their brain to those stores to access that information? And what you did is you had only part of the visual information, and you weren't wrong. You're just not complete. This is an MRI of his brain, and I think you can all see that that part of the brain which is responsible for storing that semantic information is degraded. It's all, this is on MRIs, the left is on the right and the right is on the left. And so as you can see here, the left temporal lobe is all atrophied. So that part where the coding of the semantic information lives is degraded, and he's losing his stores. So when he's in spontaneous speech, when he's trying to talk, he has a lower number of words. He has fewer words than he should have, and he's not making the right connections. One of the things that semantic knowledge allows us to do is to put things in different groups. So for instance, a cow, a horse, a sheep, and a pig are things that you would see
On a farm.
on a farm. Thank you. They're all also four-legged. They're also all mammals. A cat, a dog, a rabbit, a bird, a hamster, and a mouse are things that you might have as pets. So that kind of information, the way it's stored, the way it's classified in your brain, is also part of the semantics. And that kind of information is also lost as the disease starts to affect the structure of the brain that codes for this information. So in part, in answer to our little mishap a few moments ago, probably not a mishap, that's not the right word, but is the problem with naming things because they can't see it, because they're not seeing it properly? Well, here's an example of two stimuli that the patient has been asked to draw, so to copy the stimuli. So the stimulus of the cow looks like a cow, udder included. The stimulus of the elephant looks like an elephant, trunk and what do you call those things? Tusks. Tusks included. So you all know that that is a cow and that is an elephant. But if the patient is asked to name them, this particular patient that drew them, he calls that a dog, and he calls that a cow. So there really is a loss of the connections and the structure of how these animals are related to each other. And it's not because he's not able to see them or perceive them, and certainly he's perceiving enough detail to draw them and to differentiate them, but the connection that says that's an elephant is not there anymore. And that can move on further and further deeply to the point where all animals look alike. So this is a picture of a cat and a chat, a cat, and this is a picture of a poule, a chicken. And if you push that a little bit further still, if you're unable to really differentiate if you're unable to pick up and to understand those things that make a chicken different from a cat, you might not be able to really to appreciate fully that these three items are not real. You'll see these three items and you'll think, oh well, I don't know what that is, but, and you might actually stick your, pretend to stick your fingers in the two holes and go like this, but not appreciate that it's not really a pair of scissors. Or try to use it to pull out a cork.
When you said that they don't appreciate that they're different, is that what it is, or are they just grabbing a word that is now suddenly is a category of 20 different things that are...
You mean here?
No, the next slide. The next slide.
Oh.
You said they don't appreciate that they're different from each other, but they see that they're different, right?
Yeah.
They just put categorical.
I think every patient is different, and this is one particular patient that was asked to draw a cat and to draw a chicken, and basically drew the same organism, the same animal. So to your question,
Those look different to me.
do they?
Yeah.
They have very similar features. I mean, the ears, they both have like a tail, they have 4 feet, They have pointy ears, although this one has their ears backwards. They have eyes on the sides of their head and a snout.
I think the one on the left has a beak.
A beak?
The one on the
Okay.
right has a snout.
I don't know that. All right.
I see it was vastly different.
Neither one has a tusk.
Neither one has tusks. None of them have. Well, maybe the cat has feathers. Well, I think that's the point. Is that you, in the logic of our own minds and of the way we structured these items in order to make sense of them, that logic isn't there anymore, and so the links may not be what we expect them to be. Typically, the links become more general. So she's been asked to draw a cat and drew that, but if she'd seen that object, she might not have said cat. She might have just been able to say animal. She might not have been able to say, oh, this is a cat. So when you're asked to label something, your ability to label it is not going to be random. It'll be superordinate. You will lose the finer details and fall back on the general group names. Does that make sense? One of the ways we test this in clinic is this test called the pyramids and palm trees test. It's pretty simple. And this is really testing your semantic knowledge of things without actually asking you to describe in much detail. All you have to do is pick the bottom image that goes with the top image. So the test is called the pyramids and palm trees test because that is the match that you're supposed to do. The idea is that the pyramids are in the desert, palm trees are in the desert. You're not going to find pine trees in the desert. Unless, of course, I don't know how many pine trees there are on Las Vegas Boulevard, but there are certainly palm trees there as well. So a simple test like this will probe, without formally asking you to think about these things, it will probe your semantic knowledge of these objects and allow you, and then that integrity of that knowledge will allow you to group the pyramid and the palm tree and leave out the pine tree. So loss of vocabulary stores or connections to them is what we've just described. And the disease that, the prototypic disease for this is semantic dementia. And I showed you a picture of, or a small video of a man, and I showed you his MRI. Semantic dementia affects specifically that part of the brain where the semantic information is stored. But that kind of information is also lost in Alzheimer's disease. It can be something that presents early in Alzheimer's disease. It's not typical. Typically people present with memory loss. But occasionally the ability to access our semantic stores is interrupted or affected in Alzheimer's disease. The typical form of Alzheimer's disease is this amnestic form. That's the memory form of Alzheimer's disease. When language is affected, and language is the most prominent feature of early Alzheimer's disease, we actually call it a logopenic aphasia, because the person, logopenic, logo meaning words or language, and penic meaning little, a little bit. You've heard of osteopenia, when your bones are thinned out. Logopenic is when you have few words, when you have trouble finding your words. And so the logopenic aphasia of Alzheimer's disease can be the first manifestation of Alzheimer's disease, although it's much, much less common than the amnestic form. And typically, patients who have this have significant word-finding difficulties. They can't string a sentence together. They're always halting through, and it's difficult for them and difficult for people listening to them. Lots of word-finding pauses. People with semantic aphasia, semantic dementia, can't name objects. They have a profound anomia. So you show them pictures and they don't know what those things are. So they can't even tell you about them, they can't name them. Patients with logopenic aphasia also have trouble naming objects, but they can frequently tell you a little bit more about it. Like a pair of scissors, they might not be able to say scissors right away, but they'll be able to show you how to use them, or say to cut, to cut. You know, they'll give you a little bit more information that tells us that they know what that object is. So in answer to the question, giraffe, they'll say, oh, it's that long neck animal that lives in Africa. Instead of saying something like giraffe, what's a giraffe? Yeah. So that's picking your words to say what you want to say. The next task is to put the words together in a way that other people will understand what it is that you want to say. And there are rules that allow us to do that. And the rules are the grammar. Now I'm going to take a sidetrack for a few minutes to talk about more other parts of the brain. This is the left side of the brain again. And you can appreciate the different colors here. What I want to point out in this particular picture of the brain is the purple parts, which are called primary areas. This is the primary motor area, and that's the area that controls all of the muscles in our body, including the muscles in our throat, our tongue, and our lips. Another area is the primary auditory cortex right here. That's where information coming from the ear first arrives in the brain. And that's the area where you decode information that you hear. So decoding the sound of a dog or decoding somebody speaking. And the third area is the primary visual cortex, this area here. That area is important in decoding or taking, understanding what you're seeing. I mentioned that the primary motor cortex, the strip here that's in purple, controls every part, every muscle in your body. And Wilder Penfield, who was a neurosurgeon in Montreal, he actually mapped out all of the different areas here along the strip and found that the areas that are closer to the ear out here control the tongue and the mouth and the lips. And as we work our way upward, the hand, and then the body, and then the parts that are inside and between the two sides of the brain control the legs and the feet. So that'll be important in a few minutes, remembering which part of the motor strip controls movement of the teeth, the tongue, and the lips. This is a picture of Pierre-Paul Broca. He was a neurologist and a surgeon in Paris in the late 1800s. And this is one of his most famous patients. His real name was Le Borgne, Mr. Le Borgne, but he's better known as Tan. He's known as Tan because that's the only word he could say. Whenever you asked him anything, he would say Tan, Tan, Tan. He would modify a little bit how he would say Tan, Tan, or Tan, Tan. But that's the only utterance that he could make. When Mr. Le Borgne passed, Broca was able to examine his brain, and he saw this. This is Mr. Le Borgne's actual brain. Mr. Le Borgne had an injury to part of his brain, which we now call Broca's area.
Broken area?
Broca's area. It was, but it is, in this case, it is broken, although in most of us it's not. It's called Broca's area now. And Broca postulated that this part of the brain is necessary in order to put words together, in order to understand grammar and put a sentence together, which is what Tan or Mr. Le Borgne could not do. About 10 years later, another neurologist in Germany called Karl Wernicke had a number of patients that didn't understand when you spoke to them. They were able to put out all sorts of crazy speech. In fact, they would produce an unintelligible speech generally. But what was most characteristic of them is that they didn't understand what you were asking them to do. And he found that most of those patients had lesions in this part of the brain. Now you might remember from the other picture I showed you earlier that the part that controls speech, the part that controls the mouth and the tongue, is this part of the motor cortex over here. And this is Broca's area right beside it. And you might remember that the part that hears sounds is over here, and this is Wernicke's area around that. So if you think about what it is that we do when we speak to each other, someone says something, it enters our ear, it's brought to the area of the brain which decodes auditory information, and then it's transferred to Wernicke's area, which then decodes it in order to produce words and meanings. And then when the person wants to speak back or repeat, that information is sent to Broca's area where the grammar is put together, and then there's a connection to the motor area that controls the tongue, the vocal cords, and the lips. It's pretty complicated, but it's very interesting.
Yeah.
So that's what we're trying to do. We're trying to structure our message with grammar. And as I mentioned, this is the realm of phonology, of grammar and phonology. So grammar is the ordering of the words at the level of the phrases and sentences, and it uses certain rules. And phonology is the actual selection of the sounds that we're going to make, how the sounds are going to come out. So if you see this, and I ask you to tell me, I'm going to pick someone else now. Gentleman in the gray shirt, the glasses. What's going on here?
It looks like a young boy is pulling a young girl in a wagon.
Right, exactly. So that everybody understood that. That was a very good, sir. A very well constructed sentence that actually included a lot more detail than's already put there for you. But you could have gotten away with boy pulls girl. Could have gotten away with that. It would have been minimal, and it might have said to me that maybe you're having problems with your grammar, with all of the other words that you have to hook together in order to put a full sentence together. But you included the boy is pulling the girl, you added young, pulling the young girl in the cart. You could have said westward or forward, or, and it looks like they're having fun too. So here are ways in which you could have said that. The boy is pulling the girl. It is the girl who the boy is pulling, or it is the boy who is pulling the girl, or the girl is pulled by the boy. These are all saying the same thing, but they're saying it in different ways that use grammar. So if your use of grammar is broken, then you won't be able to come up with these complex ways and sometimes these nuanced ways of saying something. So you might come up with something very telegraphic or disjointed, like boy pulls girl. Although you will have all of the information. You will have had boy, you will have had pull, and you will have had girl. You might not have had cart or young, but you will have the basics. So things like plurals and tenses are usually lost when Broca's area, or the area that controls grammar, is broken. And sometimes people with Broca's, damage to Broca's area, they have trouble with yes, no. They might say yes and then no, 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 I meant no. Or with him and her, they'll flip those. The next thing I'm going to show you is an example of a woman, a very famous woman actually, who passed away a couple of years ago with a disorder called cortical basal degeneration. But her primary presenting symptom was a disorder called progressive nonfluent aphasia. And you'll see what's happened to her language. She's going to be describing this scene, which is part of the Western aphasia battery.
And I'd like you to take a look at this picture and take your time, and please tell me what you see. And I'd like you to take a look at this picture and take your time, and please tell me what you see. And if you can, please try to speak in sentences.
So that's key. Speak in sentences. So she wants, her name is Anne, it turns out. She wants Anne to speak in clear sentences.
Okay, take your time. I know this is a little bit difficult. Tree. People. Dog. Man.
You get the point. she's not able to put sentences together. She's actually pretty good at naming things, and if she goes on for another 45 seconds or so, and she'll name all of those things. She'll name the kite, she'll name the boat, the sailboat, but there's no structure to what she says. She can't tell the story of there's a couple at a picnic, the children are, there's a younger boy flying a kite, there's somebody out sailing a boat. All of that information she's unable to communicate that.
Gotcha. Sorry to interrupt you again. Is there a way to tell if she knows the story and can't verbalize it, or if she doesn't know the story?
There are ways. For instance, there's another scene called the cookie theft scene, where there's a young boy standing on a stool trying to take some cookies out from a jar in a cupboard, and he's falling. So you show them the picture and you say, is someone going to fall? And they'll point to the thing, okay, boy, fall. So yeah, they capture the picture, they understand what's going on, they see the salient features of the picture, but they can't bring them, they can't bring that salience into the foreground by using sentences. Does that answer your question? So there are ways. Although this is not a picture of her brain, it's a picture of somebody who had a very similar disorder called primary progressive aphasia of the non-fluent type. It's a non-fluent progressive aphasia. And what you can see is that that area where Broca's area is has been slowly degrading, slowly degenerating. So the picture on your left is 1 year after the onset of symptoms that were fairly mild. And the picture on the right is 3 years after that. And you can see that the disease has affected that part of the brain which controls putting together sentences using grammar.
What do you think is causing the disease to that part of the brain?
There's lots of theories as to why the disease is so specific and selective of that part of the brain. And there's no answer. Probably genetics. Some of these people may have had dyslexias when they were younger, so maybe that part of the brain is already sensitive to begin with, but there's no good explanation. And finally, I only have 2 minutes left. I started a little bit late. I have about 5 more minutes, so if you guys don't mind going over, I'm going to continue at the same pace. Is that all right?
Yeah.
So the last part, we've talked about putting the sentence together, putting the idea in a grammatic sentence that makes sense for other people to understand. That's all still in your head. That hasn't come out yet. When it comes out, you need to take those words and that sentence and decode that and deliver the message using motor systems. Are there any musicians in the audience? Can anybody tell me what this is?
It's an orchestration.
It is. Many instruments. A whole orchestra worth of instruments. It's Beethoven. Da, 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 da. Yeah. The most famous 4 notes ever played by all of the instruments all at the same time. Da, 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 da. So yeah, it is Beethoven's 5th. I show you that because that's what you do when you take those words that you've put together as a sentence and you say them. It's very complicated. You have a whole orchestra of little muscles and big muscles and the tongue and the vocal cords and your lungs that are all doing different things, and they have to do it in a very specific way in order to say a word that the person listening to you is going to understand. So it's very complicated, and we don't actually think about that very much. So here are the phonetics. This is a phonetic chart. There are more phonetics than there are letters. So motor programming is the conversion of the articulatory score into a phonologic structure. It's the other way around. The sentences are converted into a phonologic structure that becomes the articulatory score. Just like the musical score tells the audience what to do, the orchestra what to do, this tells the motor systems, the vocal motor systems what to do. So it directs the relevant muscles in the vocal tract to produce a word or a phrase. So people who can't do that, people who that system is broken down, they know what they want to say. It's in their head. In fact, they could probably write it down if you ask them to. They could probably write it down fully, in full grammatic form, but it's not coming out of their mouth. So this is more getting the word out than it is finding the word. And just to give you an example of how complex that is, think of the sound S and the sound Z. So say the sound S.
S.
No, just the sound, not the letter, the sound. Now say the sound Z, or Z. What's different?
Your tongue. Yeah.
The only thing that's different, the tongue stays exactly where it is, the mouth stays exactly where it is, everything stays exactly where it is. The only difference is the vocal cords get involved. The vibration in the vocal cords. Down here. So that's the difference between S and Z. Just one little switch that's turned. Imagine all of these other sounds that I'm making while I'm trying to speak. So when that system breaks down, speech sounds, what we experience are speech sounds errors, or what we call phonemic paraphasias. Frequently these people have a lot of hesitation, they stammer, they stutter, and they'll also do strange substitutions. So instead of saying crayon, they might say carbon, or they might change a few letters, change the orientation of the letters and say aminal instead of animal, or elephant instead of elephant. That's an omission. Or additions, hippopotamus instead of hippopotamus. Now, I was looking for a video of somebody that does this, because it's so, we see it, but I haven't seen any good videos of it until last night. This woman, who we're going to hear, had a stroke. This is the only example of a stroke I'm going to give you. And she put this up about a week ago. She's undergoing speech therapy in order to help. Now listen to how she speaks.
Hi, my name is...
She's not Australian.
Gina. I am 43-year-old. I have praxia speech. I have stroke 6 months ago. I still smart.
She's still smart.
Funny, but what I want to say, not get my brain to mouth. So
the connection between her brain and her mouth is broken. So very telling, very, very personal story. In fact, she goes on for a little while. But that's a stroke. But there are conditions, in particular, conditions that are very similar to the condition of the woman that I showed you, Anne, who was naming the objects one by one instead of using sentences. There are conditions that begin exactly like that, very slowly stripping away at our ability to put the sounds of the words together in a way that makes sense, that makes the words sound like words. And that's called progressive dysarthria or progressive apraxia of speech. Now, I've got 2 more slides. I wanted to use the word fluency because it's frequently used when we talk about speech. You probably appreciated that the first gentleman that I showed you spoke a lot. He used a lot of words, and he used his hands a lot, but what he was saying didn't make a whole lot of sense. That's high fluency, normal fluency speech. Low fluency speech is when we're stuttering, when we're struggling to find the words that we want to use. So the outflow of the speech is slow, laborious, and difficult, and often very frustrating to both the speaker and the listener. So the word fluency describes the flow of speech. And we can calculate fluency. We can say, well, how many words does the person come up with in 1 minute, spontaneously when they're speaking? Other things that can occur when fluency is low, well, the sentences are often very short. Ball, hit girl, or boy, pull girl. So the phrases are much shorter. The melody, the music within the words, when we modify where we intonate on the words, that's often lost when fluency is lost. And as you noticed in the last example, when we have apraxia of speech, it's a very striking example of low fluency. This particular low fluency in this woman is not because she can't come up with the words, it's because she can't put out the words. But if she could put out the words, I bet you she could come up with the words and would have normal fluency. One of the risk factors for getting transient global amnesia is having had transient global amnesia. So if you have it once, there's a risk of you having it again. We don't entirely understand the mechanism. There's a couple of theories. One is that it might be epileptic. One is that it might be migrainous. One is that it might be vascular from blood vessels not working. I think the migrainous phenomena is the one that's most favored right now, that there's something like a migraine-like phenomena that occurs within those parts of the brain, and that's kind of shut it down, and then as the migraine passes, it's not a migraine that causes a headache, but a migraine that causes dysfunction of that part of the nervous system. As the migraine passes, the system sort of resets and starts functioning again. So if you think about it that way, well, migraine is a fairly common phenomena that is recurring.
He was a pharmacist for 50 years, but he didn't have migraines after he discovered something.
That we know of.
He didn't have migraines for umpteen years before this happened. Still, though, could be.
Could be. Well, again, you know, there are different theories, and it's certainly not your typical migraine. You know, the migraine with a headache, pulsating, visual flashes, and maybe a little bit of trouble speaking. But
yes. Does traumatic brain injury directly relate to having dementia? Is that like down the road? Is there a connection there with TBI and dementia?
Well, if you look at, and this is a bit of a controversial topic, the concept of chronic traumatic encephalopathy, or punch drunk, or dementia pugilistica. These are the disorders that I think the prototypic example is the boxer that's fought all his life and has been knocked out 10 times. His brain has been damaged, and he suffers from both a motor and a cognitive syndrome, which is akin to dementia as they get older. And that's because the brain has been damaged, and over time, these different, each event has added a little bit to the overall picture and led to a state of dementia. Traumatic, the TBI, traumatic brain injury, if it's only one event, the question is, how bad was it? You know, was there a skull fracture? Was there destruction of brain tissue? Was there an actual concussion or not associated with the traumatic brain injury? And if it's only one, another question is, how old was the person when it occurred? Is the person's brain in a state where it can regenerate or it can fix itself from the event? Or did it occur when they were older, where the damage might be a little bit more permanent? For the dementias of older age, the dementias that occur in the late 60s, 70s, 80s, these are probably not the same dementias that occur in patients with young onset Alzheimer's disease, for instance. They're probably due to a mixture of problems, not just one single process. And so TBI will fit in that picture. So you'll have a little bit of Alzheimer's disease, a little bit of vascular disease, and probably a little bit of TBI added in. So if the TBI wasn't there, they'll still get it, but they might get it later. Does that make sense?
Yeah, it makes a lot of sense.
So, you know, you could walk around your whole life with a helmet on your head if you're prone to hitting it. And that's what we do to patients with epilepsy, because we know they're going to hit their head a lot. But for most of us, it's not really an option.
People who suffer from migraine is more able to get dementia?
I don't know that there's a link between migraine and dementia per se. Certain types of migraine, particularly severe migraines, can sometimes lead to strokes. To damage of the brain, yeah.
In some, it's like a little strokes.
Yeah. Yeah. So, for instance, women who smoke and who take the pill, the contraceptive pills, are at higher risk of suffering from brain damage from stroke in association with migraines.
Oh, okay.
So, obviously, in the context of multiple things adding up to produce a dementia, it would be better if they didn't have those. And in fact, when women of 30, 35 and over who smoke, who have migraines, we often tell them either you stop smoking or you don't take the pill. You know.
Oh, I don't smoke,
or
I don't take pills. And I suffer since my 20s.
Yeah, from migraines.
But my son bought for me in Australia, cephaly something that give me some
electric waves. Yeah.
And I put it in my head. Every time I get it.
Migraine.
It helped me,
helps a lot.
But I don't know if it's
safe.
Bad.
Yeah. It's very experimental. There's a lot of research right now going on in other forms of brain stimulation, either transcranial magnetic stimulation or there's a continuous current stimulation where they actually just pass a very, very slight current from one point to another along the scalp. And that can actually, it could potentially prevent migraines by changing the way the sensory neurons are firing. We also know that it can affect the brain and how it functions. And it can help depression, for instance.
Depression.
Yeah. But what the long-term consequences of that are, we don't know yet. It's been only a couple of years since we've been studying.
Thank you.
Yeah. I think you had a question. You had a question? You did not purple shirt, long blonde hair? I'm looking straight at you. Yeah. You didn't? I saw you had your hand up there.
Over here.
Okay. Sorry.
Is there an advantage to early detection
of Alzheimer's? Well, it's a loaded question. The first and obvious answer would be absolutely. We have medications that are going to stop the process, but that answer would be false. We do not have medications that will stop the process. The second answer is, well, if you know, then you can do everything you can to help your brain fight the disease and be healthier. Well, you should do that anyway. So that's not a really good answer. Another answer is, well, it's important to know where you're going to get a prognosis, an idea, and the earlier we can get it, the more you can enjoy your life, as the disease progresses, so that you know how to plan your next 20 years or your next 10 years. The first answer, we have a medication that will stop the process. I think we're very close. I think we have clinical trials going on right now that are trying to stop the disease before there are any symptoms. So we really are at that cusp where we need to be able to diagnose the disease earlier and earlier in order to start treatment that's going to stop it or slow it down. And we are doing that. We're doing that with patients who have a genetic disease. So we know they're going to get the disease, but they haven't gotten it yet. And we're doing it in patients who are at high risk of the disease because they have a certain number of genes that increase the risk that they get it. Not necessarily going to guarantee that they get it, but increases the risk that they get it. That's one of the studies that we're running here called the Tomorrow study. And we also have the PET scan that we can do now that can tell us whether there's amyloid plaques in the person's brain. And if we see amyloid plaques, we can't say when they're going to get the disease, but if they live long enough, they will. So those are the kinds of people you probably want to be treating before they get symptoms. Whether when you get the very, very earliest symptoms is a good time to treat, it will be. There are other medications, the medications, the conditions that I just described where we have people with genetic disorder and people that have amyloid in their brain already, or people who have the genetic risk factors, we're generally trying to treat these people with medications that are going to prevent the accumulation of plaques. But people who are getting very, very early symptoms, what we want to be treating is the accumulation of tangles, the tau part of the disease. The disease is caused by two different types of proteins, amyloid plaques and tau tangles. And when the tau tangles start appearing, that's when the symptoms start appearing. And so we know that when people are having symptoms, it's because tau is starting to accumulate. And that's probably a good time to start using anti-tau medications. And those are in the pipeline. There's a couple that are going to be investigated in the years to come. Does that answer? Personally, do I want to know or not? That's a very difficult question. But I think more than do I want to know is when is it going to happen? I think that's a more relevant question. That way you can sort of plan things out better.
I want to share this with...
I think she did have a question this time.
Okay. Yeah, so there's a possibly a genetic predisposition for it, because my aunt has Alzheimer's and Lewy body disease. And actually, we work with a doctor, and I've never known of anybody in the family having it. And she's at a point now she just rambles and rambles. And she doesn't like what her caregiver is saying. She'll tell her to shut up.
Well, Lewy body disease is a different story to Alzheimer's disease. There's probably a few genetic factors that influence Lewy body disease, but typically Lewy body disease is more of an environmental disease. It occurs in people who have worked on farms or have worked with chemicals, pesticides, who drink well water. So the genetics are probably less relevant, a little bit less relevant. For Alzheimer's disease, there's lots of genes that we're discovering that are risk factors. There are genes that cause the disease. There's a PS1, PS2, APP, the 3 genes. If you get those genes, you get the disease, it's for sure. But the disease starts in your 30s. You either get the gene or not, so half the people in your family are affected. It's very clear disease. But all of these other risk factors, you've probably heard of ApoE. The ApoE, it's been around for about 15, 20 years now. We know that having certain copies of the ApoE gene will increase the risk, so that instead of getting the disease at 80, you'll get it at 60, for instance. So that's one example of a bad hand. But there are many, many types of genes like that will influence when and if, not if, but if you get the disease, when you'll get it. I was talking about the Tomorrow study where we study people who are at risk. That's yet another gene that increases the risk of getting it. So the more of these genes you have in your hand, the more likely you are to get it, and the younger you're likely to get it.